Okay, so as you know, this is an area that exploded with information, and that is because of the sheer volume of research that's being done in this area. And so when you give a talk like this, be prepared that tomorrow I could have a different opinion. And that's only because of how the information comes out in such volumes and over time. So this is really an important attempt to try to get at all the information as it stands right now, and then try to answer everybody's questions. Okay, so here we go. So as you know, if you've been with me before, I have the disclaimers, and I have all the things I said, didn't say, and I don't want you to say I said, and all that kind of stuff to kind of protect me. And also people that I work with that I appreciate very much. And of course, I always have to give thanks to my family. Here's a picture of 3 of the boys. And so at least that's why I work so hard. As you know, because I also give these talks to physician groups, I do have to disclose the books that I wrote for the American Medical Association, because I get royalties if people buy the books. So nobody can say you didn't tell me, I didn't know about that. So those are all the books and ones that I've written. With specific reference to Corona, as many of you know now, we've been doing the different updates. And the Corona, we now have one actually in May, but we're hoping to come up with one. I've been pushing the group for us to try to do another updated national guideline. So this is the national guideline. You can get it at this MD guideline. See that right here, MD guidelines. You just get that right there, and it's available for free. You don't have to pay for that because it's published for free for everybody's distribution. Some of the other research papers that I've published are here. Again, just to let you know that they're out there. You can always just look them up on the web of things that might be of assistance to you in evaluating how these affect people. Okay, so rest up, what we're going to talk about, right? So I'm going to do a brief history, just briefly. We're going to do the testing and immunology and some current experience. I'm going to try to get through all the information. Please don't get worried if your brain gets a little bit fried because there's a lot of stuff coming your way. It's kind of like drinking from a fire hose. But the intention is to try to give you as clear science as I possibly can. Once again, I'm just going to remind everybody, please keep yourself muted at all times. So, brief history. People are always asking me, where did this come from? How did it get started? Stuff. So again, we've seen epidemics before. We've seen pandemics before, right? In this particular case, what is the current science and understanding of the origins and stuff? I get this question all the time. So currently, there was a whole thing about this jump from horseshoe bats and all this kind of stuff, and this does not look likely. The bats were not endemic to Wuhan. There was some suggestion of animal hosts. That does not look to be likely. There was gain-of-function research, which was funded by the US. That does look to be more likely, which is a certain method of trying to make viruses and bacteria have additional properties. And when they get those additional properties, then they're more able to infect people or perpetuate themselves. And we saw that the prior SARS emerged. Remember from my past talks I talked to you about when we had these other infections in the past. And indeed, about 10% of those cases did not have spread, which means that you did not get a large spread of these things because they didn't have that gain of function ability, that manipulation of the genome thing, which seems to be happening. We also know that because of the way this one's behaving, it's pretty fast human to human, and this suggests it had been out for probably a few months before we became aware of it. The timelines that people talk about, here's the timelines that people talk about, the big area of focus, which, again, I'm never sure you're going to get an answer for, but just everybody always asks me about this stuff is, when was their first indications? Probably in September 2019. The Wuhan lab had some deletion of bat sequences, had some change in the security protocols, put out a request for change of ventilation system, the kind of things you usually see when there's been some major changes or shifts. So again, when people ask about that stuff, that's just, what it is. I don't have a big horse in that race, but just to be honest with you, that looks what it's going to be. Will you ever get straight answers about all that stuff? I doubt it, but anything's possible on that. Okay, so rest up. Here's some of the family. And what I'm going to do now is I want to talk to you about the testing, right? So in testing, I'm going to remind you again, this is very important to remember this testing, okay? So look, okay, don't say, I didn't go to medical school. I'm not into this stuff. You got to hear it. You got to know it. You got to have this drilled into you every single time. Okay. We have macrophages. Those are the cells that look for weird things called antigens, which are viruses, bacteria, substances that shouldn't be there. And when they see it, they start sending out messengers to the T cells. The T cells do two things. They more T cells and they stimulate B cells. The B cells are the ones that produce the antibodies. But look, this is very important. Look at this. You have two different methods of immunology, the cellular and what's called humoral or the antibodies, which means that when everybody's talking about antibodies, they're not talking about the cellular response, which is also there, which is why there's going to be some discrepancies about why people say, well, you got to do this, you got to do this. But, the actual indications for those things can be weaker because there's a second immune system operating there, right? So what do these tests look like, right? So the blood test for the antibodies to the virus, they go against the protein, and you get an IgM, which is the early one, in 4 to 6 days, usually peaks at 12 days, and declines after 35 days. The IgG peaks around 10 to 18 days. Now, when you look back at the old SARS or MERS, those IgG antibodies lasted up to years. Now, people are going to say, yeah, but I heard that it's all dropping off and you got to get boosted up. We're going to talk about the boosters, right? But I want you to understand that there's going to be some antibody residuals, right? So if you look at this on this kind of time frame, right? Look. Here you go. You got SARS, you come into contact. So all of a sudden, you start getting that rise, and where you could possibly see some antigens. You could probably see something if you're doing PCR tests, and then you get sick, right? This is sick. And then after you get sick, right? So those things start to drop off. The virus starts to drop off. But what you do start to see is the rise in the antibodies, right? And that's what they go over. That's why they call it antibody detection at that period of time. So that's when you know that's going to be happening, right? And this very important study, I want to remind you of this study, right? This is out of Crotty's lab in San Diego, right? What they did is a couple things. One, they tested people and they said, every single person we've tested, 100% had T cell response, right? So keep that in mind, please. Please keep that in mind. Yes, you could test people, and yes, you might not see a lot of antibodies, but they have the T cells activated. There is some immune defense by infection, right? Number two, they took people and they said, let's take blood from people that we have in our lab from years ago. This is blood from 2015, 2016. And that blood also showed reactivity to corona. You could say, well, how's that possible? So you may remember that I told you about the past infections, right? In past talks, we've talked about when you had coronavirus, there were coronaviruses that caused bronchitis, that caused simple infections, that caused sore throats, right? So we've all been exposed to coronaviruses in the past. So we all have some level of immune response already, right? And that's why there's going to be that difference, okay? Now, if you look at it in a different way, in a natural infection, somebody gets infected, what happens? So you can see those T cells and B cells go up, and also you can see the antibodies go up, right? And that's going to be the pattern that we expect that's normal, right? And so when we look at some of the studies, when you actually do testing of the blood from a natural infection, look at this. Green is asymptomatic. Blue is 1 to 5 symptoms. Red is 5 symptoms. So you would say the people with red are probably going to be the more symptomatic folks. Fair? And if you look at all these people over time, right? Look at the time in days here. Look at how many days, hundreds of days. Those antibodies stay positive a long time, right? You're getting out to almost 300 days in this study, right? So fair enough. That means that this is consistent with a lot of those studies that show that the IgG antibodies hang around for a long time, probably for years. Is there a drop-off? Yes. Do some people drop off more than others? Yes. But is there going to be evidence of testing where you can really see antibodies for a long period of time? Yes. Please keep that in mind. Now look at this. I know this is busy, but stay with me. These are different studies that look at the antibody responses after you get immunized, right? So this is where they're looking at what happens to the antibodies over time. I know it's a little hard, a little busy of a slide. Hope you got a big computer screen going right now, but the message is the following. It goes up and it will stay up in virtually every study. It does not stay at that very high level forever. It does start to drop down a little bit over time. That's true. And that's why we're talking about those issues that have to do with boosters and antibodies and how much it impacts people. But there's no question that you get huge antibody responses to these vaccinations, right? So antibody levels will be lower in asymptomatic people. Antibody levels may drop quickly, but even if they drop quickly, if you get reinfected, meaning you're exposed to somebody else, there's no question that overwhelming data, you're going to have less illness. The durability of these antibodies is now at least 18 months and ongoing. And not all the antibodies fight the infection. This is going to be very humbling information for you. There is good data that some of the antibodies we make, when they attack the virus, they actually cause a change in the shape of the virus, which can actually permit more infection, not less. Very difficult, very humbling, but it does happen, okay? At 6 to 8 months, you generally have about 25% of those neutralizing antibodies, but there's studies that show that you only need about 3% of neutralizing antibodies to prevent severe infection or death. So think about that. When it says, oh, I had a blood test that doesn't show anything. First of all, we're not testing for T cells. We're not testing for B cells. The antibody levels could be very low, but you have protection. Is it as much as having as high antibodies? Probably not. But if you get 20% of the antibody levels that you used to have, it still protects you about 50% of the time, meaning that about half the time you won't even get any kind of illness. You won't even be aware that you have anything, right? Next, this is very important. The lab methods that are used to claim efficacy for a vaccine have a lot of methodologic variation. Why I'm telling you that is the following. It gets a little technical, but it's very important. There is no perfect lab test. There will never be a perfect lab test. Every lab test is influenced by how it's run and how it's handled. Therefore, you will have descriptions in the papers about, oh, this one's 78%, this one's 82%, so this one's not good. Look, within realms of medical variability and methodology, they're probably about the same. And you should not be focusing on that. When people say to me, well, I got the Johnson & Johnson and now I see it's only 70, or I got the Pfizer, it looks like Moderna's a little bit better. These are very subtle variations on a thing, right? Neutralizing antibody levels are predictive of immune protection. So this is something that I'm going to talk about when we talk about the third dose later on. Okay, so keep that in mind. And at least 90% of people develop antibodies after a natural infection. So if you had the infection at any time, you have a very high likelihood of a strong response and clear evidence of protection. Okay, that's a rest stop. So that's a little bit about the immunology. I know it's a lot of information. I know it's a little difficult, but I wanted to share that with you. Now what we're going to do is we're going to talk about the vaccine types, and how it has to do with those variants, and then we'll try to round it up from there. Okay, so here we go. Last time I think I gave a talk, I talked about the different types of vaccines. So I just want to remind you of this because there are 4 different types of vaccines, and I gave you examples of the different types of vaccines. So some of them we've known for years and years, right? Flu, polio, rabies, measles, mumps, rubella. And obviously, the mRNAs are the new kid on the block, which have been an amazing medical accomplishment like nothing else we've seen in medicine. It is historical and incredible. It gets overshadowed by a lot of other media that diverts attention from that accomplishment. It was an amazing accomplishment and a great credit to the whole pathway that set that up and how it happened, right? So when you hear about vaccines, right? So there are the viral vectors, There are the genetics, there are the virus-based, and then there's the protein-based. So as you know, the genetic ones, that's the Pfizer, Moderna, the first two big mRNA ones that everybody's heard about, everybody's talked about. Those are the ones that have really a unique, novel, incredible advantage of production and ability to come out. You see the other viral vector ones that are in process. And there's a whole timeline here of where they are, where they're not at. It turns out right now, the Sinovac and Sinopharm, which are the virus-based ones using a killed vaccine, are not doing quite as well as some of the mRNAs and some of the other ones like Novavax. We're seeing some protein benefits there, but again, some trade-offs, right? So let's go look at this, right? So you have the Pfizer, Moderna, the mRNAs. You have the recombinants, right, which use different mechanisms of generating their use. Right now, we're still on emergency use authorization for the mRNAs. That will probably come up, I would guess, in September when they've been administered enough and followed up enough that it will get full authorization. Because I actually have people who said, well, I'm going to wait till the FDA says, okay, it's approved, as opposed to just emergency use authorization. So please keep a look on for that, because that will be coming up. But what you'll see is that at least in these, you have these huge numbers of efficacy against symptomatic disease. This is incredible levels. We would be happy when we give a flu shot and we think that we have 30 to 50% crossover to the antigens that are circulating. This level of overlap is absolutely superb and way above things we've ever seen before, which is why there's a clear message about what is the goal of these vaccines. So here's an important message. Please keep this in mind. That's why I just put it by itself, right? A vaccine will prevent severe disease, and that's what we're after. We're not after infection or asymptomatic virus shedding. What does that mean? That means that throughout history, there's been viruses. There will always be viruses. There will always be variants. There's no question about that. Get used to it. It's been going on for the history of science. And we know that when we give vaccines, what you're doing is you're preventing disease. Somebody could breathe on you. Somebody could cough on you, and you could potentially pick up the virus in your nose and in your throat. And it's even possible that depending on your status, that virus could cause some disease. And indeed, it does. And we've seen those breakthrough infections, and we'll talk about that. But the vast majority of people, overwhelmingly, will have no or minimal symptoms. Very few of them will continue to transmit it. So you're looking at fractions of people who are concerned about this avenue of understanding. So I want to drive this home. Can anything happen? Yes, anything's possible, right? Let's talk about medical reality. You're doing fractions of people that could potentially have trouble. That's why when you start looking at all the recommendations, it comes down to get the shot, get the shot, get the shot, and everything else is of more marginal benefit, right? Okay, when you're looking at the safety, I talked to you before about the different mechanisms that are set up in the United States for looking at safety. So people know, Mark, are these things going to be good? What can I rely on, right? And so I'm just going to remind you of those systems that occur. One is vSafe, and the vSafe is the one which you get through the CDC where you sign up, and anybody can do this. You can sign up for the system, and the vSafe, also called Variance, is where they will have a mechanism of text messaging. Well, they'll say to you, okay, how you doing? What happens after you got your vaccine? And they have used that for abilities to track what people are reporting are their symptom complexes after getting that. And the advantage of that is that you get a huge amount of people who voluntarily say, okay, I'll let you know what happens after a vaccine, right? All right, number two, the VAERS. This is the Vaccine Adverse Event Reporting System. This is number two, another way that they track for early warning, right? And so this uses national data, and it rapidly detects safety signals. but it is essentially a system where like anybody, regardless of plausibility, can call up and say, okay, I had a headache, right? Was the headache due to the vaccine? Would they have gotten a headache anyways? It's not verifiable. But what it does do is that if you have thousands and thousands of people calling in saying, look, I've got a headache. So it allows you to start generating a hypothesis. You start saying, you know what? This looks like this could be real. And that allows for getting at possibilities of side effects and how to study for it, right? All right, number 3, CISA. This is the Clinical Immunization Safety Assessment Project. And what they do is they have 7 medical centers in the US where they have safety experts. And what these people do is they get reports and they start analyzing it for the government. And so they'll do a consultation service. And what can happen is if somebody gets complicated, somebody has unusual symptoms, somebody's having a particular problem, and it doesn't seem it's really addressed by the CDC or the American College of Immunization Practice guidelines, then you have different specialists that will look at this and they will take calls. And if they think it's very unusual, they will sometimes investigate looking for rare or unusual reactions, right? Number 4. Last system. This is a vaccine safety data link, and there are 9 participating integrated healthcare organizations that are collecting data on 12 million people, right? So what happens is these are classically like a Kaiser system or something like that, where they're taking all the stuff that they have on you from all the different areas, and they're collating it, and they're doing an electronic data search to look for that information, to look to see if there's any correlation with the vaccines and their side effects. So you can see that there's a lot of different systems in the United States that is looking at different ways of gathering information, different warning signs for that information to help guide people about what's there, what's to concern about. And the bottom line of all that stuff is that the studies that got these vaccines approved is holding up more or less in all these different mechanisms. Probably the one thing that stood out a little bit, which I have later on, is a discussion about the Johnson & Johnson, where there was a slightly more increase of a venous thrombosis issue than was seen in the original studies, but it picked it up. But it's still very rare, about 6 in a million. But nonetheless, that's what those systems do. Okay, now that's the vaccines, that's the immunology, and that's some of the safety monitoring. Okay, let's go to the variants. Okay. So these are what's called variants of concern, which means throughout history, every virus, every bacteria has always mutated. It's always done it. It's always going to do it. It's going to be with us forever. There's no way around it. And most mutations create no difference. The vast majority. The vast majority of mutations you never even hear about. But the flu has been mutating forever. And that's why every year we give a different flu shot. But a lot of mutations are not necessarily bad. Some can be different. Some can have differences in their abilities, right? So these are some of the ones that you may have heard about: alpha, beta, gamma, delta. They originally were using where they were first identified, and then they decided that they would start using the Greek alphabet. They were identified in a medical sense by this Pango lineage, but of course, that's a little harder for people to keep track of. And what it shows is that for all of these, they may have an increased transmission. See, 50% increase, 50% increase, definitely increased transmission with the Delta. And there's potential reduced antibody efficacy, potential. Some are more minimal. There's no impact on antibody therapies for some, but it starts to give you a range of understanding of why we look at those things and what they could possibly do. Now, another way to look at this. Look. This is based on time. So this is April to July 31st, which is the most recent data I could get, which looks at the types of viruses. So look what happens, right? Look how some of them get smaller over time, and then you got the Delta, which got bigger over time, right? Which we were seeing in a lot of countries. And so that's why there's been a lot of discussion on the Delta variant, because it easily transmits, and so it's going through. okay? So what are the monitoring we're looking at? We're looking at antibody neutralization. Well, we've talked about that, right? We've talked about that antibodies, what they're trying to do is what they're trying to impact and how they're trying to help. We talked about efficacy. Okay, how can you judge that? Is there some variability in the methods of looking at that? About how can you judge if the vaccines are covering these variants, right? And are we going to see breakthroughs in that? So when we look at some of the studies, this is a little busy, so let me go through it with you. Stay with me. Here's the different variants: beta, delta, gamma, alpha. Here's the different vaccines: the mRNAs, AstraZeneca, Novavax, Janssen. And you can see based on these color plots that what you get is a fold reduction, which means, stay with me, if you have a variant and it doesn't change anything, then you have no effect that's equal to 1 year on this line, right? So you see these blue ones, the mRNAs, the alpha variant didn't make a difference, right? But as you move up and you start seeing different reductions in neutralization activity, which means how well the antibody is knocking these things down. If you see that, what happens is that now you're starting to say, okay, there looks like this might break through a little bit. So you can see on the beta, there was much more reduction in the mRNAs, not as much with the delta, probably about the same with the gamma. See the numbers right here. So you can see, yes, there is some reduction, but it's not all or none. There is maybe some weakening. There is going to be some breakthroughs. That's true. But the question is, how many? It's not going to be common. And when it happens, you're going to see it much more in people that are much more susceptible to those troubles, right? Okay, now, to date, available data demonstrate antibody persistence at least 8 months with COVID-19 infection. I've got it out to 18 months. 6 months after the second mRNA, 8 months after receiving a single Janssen dose. They may maintain long-term protection from severe illness, even if it becomes susceptible to my infection. That's exactly what I'm saying. So when people say, oh my gosh, we're in such trouble here, look, you're not necessarily in trouble. There is potential waning immunity. But remember, I told you that you can have this waning immunity, but still have protection, even with a low amount of antibodies still present, right? So what does that look like? So if you look at the Pfizer vaccine for 6-month efficacy, okay, when you first get it, you're right there, right? And then when you wait out 2 to 4 months, okay, it drops low. And your 4 6 was 84% with the average between 75 and 90, right? That's true. So it is dropping off. But look. The efficacy against severe illness, what we really care about is, are they going to be in the hospital? Are they going to be intubated? Are they going to die? All of a sudden, that drops off to almost nothing, right? These things are working. They're working extremely well. And yes, can there be a little bit of drop off? Yeah, there's possible. Are you in a big risk group, right? So that's when I start saying, okay, if somebody really is worried because of their age, because of their family, because of this, because of that, all right, you want to get the shot? Yes, you can get the shot for a 3rd dose. But the most important thing, get the shot in the first place, because it works. It works very well. Okay. Now, here's the real world outcomes. The mRNA vaccines graded 85% efficacy. The gamma, 84 to 85%. The betas, depends on the dose, were more variable. But of course, we don't even talk much about the betas anymore right now, because that doesn't seem to be a big problem yet. That one statistically should have created more trouble for us than the delta. It hasn't done that so far. Okay. All right. Delta variant, what we know. It's nearly twice as contagious as the previous variants. There's some evidence of increased illness severity versus the previous strain in the unvaccinated. The greatest risk of transmission, unvaccinated by far. Fully vaccinated people with Delta breakthrough infections can spread the virus. However, vaccinated people with Delta appear to be infectious for a much shorter period of time than the unvaccinated, and it's much less of a risk. Get the vaccine. If you have somebody that you know that is not having to get the vaccine, it is so important. This is the biggest discriminator between everything else. Everybody says, well, I heard about this, I heard about that. It's orders of magnitude difference between having the vaccine and not having the vaccine, and all these little subtle discussions on the side, right? So another way to look at it. A lot of the data is being done in Israel, Qatar, Canada, England, Scotland, along with the US. When we look at people who have infections, patients who have symptoms, and those who are hospitalized. How good are we against the Alpha variant versus the Delta variant? And you could see that there was some differences, in particular in Israel. Israel was seeing a bigger drop-off in infections and symptoms than some of the others. But again, severe protection, still way up there, still way up there. So I'm not saying it's nothing, but you have to understand that we're going to have viruses forever. They're going to have variants of this forever. We're going to have variants of other viruses forever. And when you start seeing these other variants, it's going to happen. It's going to continue to happen. But how well do these behave? They behave very well. And just like every other thing, like flu, if you have somebody that's in a risk group, then they're going to have more chance of that risk, right? Okay, so differences in COVID vaccination programs. So Israel uses primarily Pfizer, now adding in Moderna, and so they have different dosage regimens for those, and that's just again trying to help people understand how do you decide what is the information here and how does it help guide you for the future, right? Declines in vaccine efficacy against infection, and this is from Israel. Again, Israel has done a lot of the forward work in this area. There are higher breakthrough rates and lower Pfizer vaccine efficacy against infections in persons vaccinated many months ago. So that's why Israel was one of the first ones saying, okay, we're going to give a third shot. We're going to give a third shot because we were so good and so efficient at getting this out to our population in January, February. Israel was the envy of the world because they were really on it very strongly. So they're saying, well, now we're seeing this drop off. And they said, okay, we're going to do these types of folks, maybe grade 60, those with immune susceptibility. Look, that's a fair argument, but there's a lot of points with that. So one point is that what I can tell you right now is when you give a third shot, you're going to get more antibodies. What I can't tell you, because there's no good studies for this yet, on any basis, do those increased antibody levels mean anything? Because I already told you that very low levels and cellular immunity are often enough to prevent severe infection anyways. So you don't really need that third shot. Next, there was the one study, which I mentioned before, that said that, well, there does seem to be some correlation with the level of antibodies and how seriously ill. That's true. But that may be in a different scenario, not in a booster scenario. Now, will there be data that comes out that says it makes a difference? It's very possible. But right now, I can't tell you that, right? There is, this increased risk of breakthrough infection. But look, the numbers are very small, 2%, 1%. So this is why when we're talking about these are subtleties on very small numbers of trying to tweak things in a certain way. And that's one of the issues that has to be reminded about very much, okay? Vaccine efficacy for hospitalization, right? So this is July versus January, May for the Mayo Clinic, right? So when you look at Pfizer seemed to have in the SARS-CoV-2 infection a little lower efficacy as opposed to Moderna. So people are saying, oh my God, I got Pfizer before, I should get the Moderna. But remember, it's very important to remember this level of efficacy is still very reasonable. And again, you don't need a lot of this to protect yourself. For hospitalizations, the things we really care about serious threats to your illness, this is still outstanding data, and they're still about the same. Remember, I told you There's different ways of analyzing it. There's different methodologies to look at vaccine efficacy. So you have to keep it in mind when you're hearing these reports that it's not all or none. It's not wildly different. It's subtleties, but the things we really care about are still being well protected. Okay. Now, breakthrough cases. Despite this high vaccine efficacy, there are some breakthrough cases to be expected. Some will be caused by these variants. There's monitoring still going on. There are 164 million fully vaccinated in the US, and there have been 7,000 hospitalizations and 1,500 deaths with vaccine breakthrough reported to passive surveillance. So what does that mean? That means that if you're looking at this vaccine breakthrough, after you have 164 million people, you have 7,000 hospitalizations. The majority of these are the elderly. Well, we knew that from the original infection. The majority of these are people that had a lot of risk. So if you're asking me who to focus on, it's what I've been saying from the very beginning. Those of you who heard my talks early on over a year ago, I said this craziness of going after the entire US and locking down all stuff, it does not make medical sense. It has always made sense. Like everything else in medicine, you go after your risk groups, the elderly, the immune suppressed, the ones that have the risk factors, right? That's where you should be focusing this effort. That's where you should be thinking about that third shot. That's where you're going to have any potential benefits at all, right? And what's the summary of these? The alpha, low prevalence, the beta, low prevalence, the gamma, low prevalence, the delta now is high prevalence, and there's a moderate impact on vaccine efficacy for infection, but it appears to protect against the severe stuff, especially the Janssen product, right? So that's really what you want to know, that yes, they exist, there will be more, and they will most likely have variable prevalence over time, and they will have variable impacts, but the vast majority will be protected, right? Now, boosters. Manufacturers are conducting booster studies right now, right? Now, look, I have no problem about vaccines. Those of you who've been with me for many years know I'm a vaccine guy. I've always do that on the physicals. I always check in with people. Are you on top of every single shot? And don't forget, flu shots are coming. I want you all to get flu shots, right? This stuff is very important. But one of the important things is, if there was a booster shot that was reformulated, I'd be much more strongly in. But right now, they're giving boosters of the same shot. Now, it raises the antibody levels. Does it do something besides raising antibody levels? I don't know. Is it worth people who get bad reactions to these shots getting a third shot? Depends on who you are. Often, given the data I've just shown you, it's not. Unless somebody doesn't have antibodies, unless somebody's in a very severe risk group, probably doesn't make a difference. It's probably not worth that shot, right? The vaccine does work on the variants. If the vaccine is 90% effective, you still have to vaccinate a lot of the population. Studies have shown that those with natural immunity do have equal, if not higher, protection than those who have never been infected. Look, I'm not saying go out and get the natural infection, but quite frankly, if you're immunized and then you said, okay, I'm immunized and I'm willing to take a little bit of a risk because I want to have a life and I want to go outside and I want to exercise and I want to interact with my family and my children and participate in the world. And you said, oh, I did that and I got infected. Look, I don't want you to get sick. I don't want anybody to die. I'm not trying to be cavalier here, but quite frankly, in a longitudinal basis, that would be a good thing because your immune system would now have both a natural infection and a vaccine, and the two together are better than either one separately. But there is some data that talks about natural immunity. That's in particular, there was a Cleveland Clinic study in Israel. They are not peer reviewed yet, but nonetheless, keep that in mind. That's why long ago people said to me, well, Mark, I had the infection. Do you still want me to get the shot? I said, absolutely, right? I said that to everybody. You may recall that. The full vaccination does provide help to you. And so I'm a big fan of that. The Chinese vaccines don't seem to work as well, but they're still better than many other vaccines for other conditions. There's one called CureVac. Don't think it was good. One of the ones I want to point out, one of my recommendations previously, I was wrong. This was on the young women. As you may recall, I said early on, I'm holding off on my young ladies because there was no good data about the pregnancy, about fertility. And so I was being very cautious. So first of all, as you recall, on my last talk, I said, well, now there's some good studies on the pregnancy and stuff. So I think the women should get it. But what I did say is I said, look, all things being equal, take the Johnson & Johnson. I said, Johnson & Johnson is the old mechanism and everybody used to it. It's only one shot. And that would be a reasonable alternative. Well, it turns out that the Johnson & Johnson had slightly greater side effect profile than the mRNAs. So I was wrong about that one subtle difference. Not a big deal because it still works, but nonetheless, I would like that, that all things being equal, I'd say take the mRNAs right now. But the most important thing, please, please, please keep this in mind. It's very important. Look. Take a shot, any shot. Any shot is better than no shot. The other things become subtleties and slight differences and slight percentages, but overwhelmingly, these things work very good and are very helpful. Cold storage has been modified, so now the vaccines can be transferred more easily. And so we've talked about the older shots. Safety maybe is not as good. You can wait after infection to take the vaccine. 20 days is mild, 9 days if you're hospitalized or got IV treatment, but you should take the vaccine. Kids less than 12, my feeling right now is you are more likely to have a negative outcome from vaccination than from natural infection. And so, so in general, for the young kids, the ones 12 and under, it's hard for me to recommend a vaccine. You have to be honest about that data. Now you could say, well, we want to do that because we're trying to prevent transmission because kids, can transmit and stuff. Look, kids are less likely to get infection. They're half as likely to spread the infection. There's multiple ongoing studies of the kids, but in general, it is hard for me to justify when knowing the data that kids do so well. This is not flu, by the way. Remember that. I've told you this before. Flu is an illness of kids and the elderly. Corona is an infection of the elderly. The kids do very well. And so that's why it's hard to justify that. 40-45% of hospitalized breakthrough cases are immune compromised, right? So in other words, when I take a straw poll of different hospitals, they say 10, maybe 20% of most of the hospitalized patients had a vaccine. Once again, the vast majority are unvaccinated. 99.5% of all the deaths are the unvaccinated, right? And so when you look at the vaccinated who get back in the hospital, a lot of them almost have some serious immune compromise. So you're getting into fractions of fractions, right? Now, the Peltzman effect is active that people change their risk after a shot. What that means is that there's medical studies that have shown that when you have a helmet law and you say to people, okay, everybody has to wear a helmet while riding a motorcycle, riding a bike, what happens? The cars start driving closer to you because they see you have a helmet, even though you're still at risk. When people have a shot, they start saying, well, I take different risks now. So they say, well, then the shots don't work as well. Well, it's not necessarily the shots don't work well. It means that they, change their behaviors with it. And so getting the raw data, especially at a full authorization, will help with the efficacy. So that's the stuff that I think is coming down the pike for us later on. The variants, we've talked about the antigenic shift, antigenic drift. There will always be variants. This will be endemic, meaning there will always be circulating variants, just like there's always circulating flu variants, but most will not cause serious illness. We're now measuring variants, but we never did this at this kind of scale before for a lot of other illnesses. So that's why you're hearing a lot about variants, because we're measuring it. You're looking for it. And when you look for something, you find it, right? And so this will be something that you will also see in other conditions, right? COVID variants are more transmissible and all contain adaptations in that spike protein. It's a normal process, and this will change under different selection pressures. By the way, an argument can be made where we talked early on in other talks about herd immunity. And there was an argument made where we said, well, look, if you had protected only the vulnerable and let this kind of run through society a little bit, you would have had the vast majority of people get sick and get better. And then there would have been a difficulty for the virus to be able to mutate quite as much because there'd be so many people already immune. But because there was all this flattening of the curve and these variable differentials, that allowed time for the vaccine to get into different selection pressures and to alter and vary itself more. So you just have to be honest about every time you make a decision, there are impacts on the public health, okay? Public health response, there's no good data lockdowns have any benefit, and there's good data that had many harms. Australia, people said, oh, well, look at Australia. So, well, okay, now Australia, because they did this huge lockdown, now they're having all the troubles, right? Don't forget, one of the other things that goes on is there's still some areas where you can't get transmission. So when people say to me, well, Mark, what about this wearing the mask? LA County right now says, okay, got to do it indoors. That's a whole nother discussion about, a county that has more people than most states, and then they take a hammer to things that don't take into selective communities. But one of the things I do say is, look, if you're in a very crowded place, I'm not talking about a grocery store, but a very crowded small room with lots of people with poor ventilation, okay, then I agree. Then there's more chance of a transmission. But once again, it's not a death knell, right? Because I've talked to you about the data, about how rare and uncommon that is, right? And there's no, in the public health, there's good data on negative impacts on kids. There's a natural variation that's ebb and flow. Now look, very important, look. Where did Delta start? It started in India. You remember the news reports? Everybody's dying. But now you don't hear that. Why? Did India magically immunize its billion people? No. This is what happens with viral infections. It ebbs and flows. That's why you have people say, oh, look, these people, they did a lockdown and look how good it worked, right? Well, that maybe had nothing to do with it, because this is the natural history of infections, right? That's very important. Please keep that in mind. There'll be people always claiming that because of what they did, this is what caused the change. But it had nothing to do with the intervention. It had to do with the natural history of infections. How does that happen? Well, because some people are more susceptible. Some people had coronavirus in the past that was due to bronchitis, and they had better T cells and B cells lying around. Some of them had asymptomatic disease. So you don't really know what caused that to stop, but there's a lot of variations in that. Next, one more thing. When you see all these reports about saying cases are rising, oh my God, this is, it's terrible. First of all, look, this is so blown out of proportion, it's beyond belief. Yes, there's an increase in cases, but I've told you how many thousand there is compared to how many people are immunized. This is almost a rounding error, right? Next, the way that they report is not honest. They do a couple things. One, they do PIC, which stands for pneumonia, influenza, corona. Anytime a patient has those things, they will say that that's counted as part of the corona spectrum. Two, they had all these things that put in place where they were paying hospitals extra money if they had corona patients. So guess what happened? Magically, all the corona claims in the hospitals went up, disproportionate to what seems to be their testing. Next, they do all this testing, but what they don't tell you is that if somebody tests positive for corona, they list it as corona, but that has nothing to do with why they're in the hospital. It's not the reason that they died. It's somebody who has corona, so it's somebody who died with corona, not from corona. That's why this data gets very out of line and bothers me terribly, right? Okay, next, a third booster shot. Probably in the future with a different formulation, maybe not as often as influenza, but if there's a different formulation, you will almost certainly see me saying yes, 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 yes. Do I support this in the immunocompromised patients? Yes. But again, remember what I showed you. It's not all or none. You're protected. You got great protection. There's very good protection. And we do not know yet what it means when you get that third shot. And what it can mean is that somebody could have trouble. They could have trouble from that third shot. What kind of trouble? Well, not just local reactions, but it does rev up your immune system. And we don't know. Is that one day going to cause some type of other immune dysregulation? We don't know. It's possible, right? And we don't know that when you get a third shot, Is it going to set up some type of trouble later on that you're resistant to a different shot? I don't know those things, right? But it seems to be a reasonable thing for my folks who ask me. I say, okay, look, your family wants you to take a third shot, take a third shot, right? Do I know what I'm doing fully? No, I don't. Do I think it's medically necessary? I think in people that say that we don't have any antibodies and they're at some kind of immune compromise, then I think it's reasonable, right? That's what I would say. 4.7 billion doses have been given in the world. The US, we've given 357 million doses. Operation Warp Speed from the past administration was incredible. That made medical history. It got washed over, but the mRNAs and that entire program was unbelievable, and we shall be very proud of it. It's a private sector that did that. It's terrific. There is this intense comprehensive safety monitoring. Overall, the safety is consistent with the trials. The bad reaction to anaphylaxis is rare. Data do not suggest that there's any kind of safety signals, and people need to take this vaccine. There will always be variants. They're here to stay. The vaccines, I think, will get better, and then we'll be out of this in that regard. Okay, now, that's it. What I'm going to do now is I'm going to go through the questions, and